Good morning, everyone. Thank you all so much for participating in this webinar. I'm Leah Festa, Director of the Prevention Alliance of Tennessee. And for those who are not familiar with our organization, we are made up of substance abuse prevention coalitions across the state. And we act as a statewide advocacy organization and facilitate technical assistance and do our best to provide training for coalitions. So today we have Karen Pershing. And I was just speaking with her, so you might have heard. We're having a little bit of a technical difficulty with getting her into the slide deck, so she might be saying next slide as we move along throughout the slides, but hopefully that won't cause too much of an inconvenience. And as far as a few procedural notes, we do have the questions in chat box in the corner there, so as we go along, if you have any questions, comments, anything like that, feel free to type those down there, and I'll keep an eye on that as well as Karen. And additionally, I'll be sending a feedback survey out after this webinar. If you could fill those out, and if you do need the CPS credit hours, please email me. It's Leah at pncoalitions.org, and I'll put that in the chat box for everybody to see as well. All right, so I want to introduce Karen. She currently serves as the Executive Director of the Metro Drug Coalition, which was formerly the Metropolitan Drug Commission. She received her Bachelor of Science in Human Development and Family Studies at UT Knoxville, and after working for many years in the public health field, Karen returned to get her master's degree from UTK in public health, and her concentration is health planning and administration. She's provided numerous trainings and is really my guru when it comes to prescription drug issues, especially when we're working on advocacy related to prescription drug abuse. So I'm going to hand it over to Karen now.
Yeah, great. Thank you, Leah, and happy Friday morning, everyone. I appreciate you all tuning in, and like Leah mentioned, we're having some technical difficulties with me being able to advance the slides, so you will hear me say next slide periodically, but just bear with us. When I started in my position in 2010 here at MDC, I started seeing some data on prescription drug abuse nationally, and then started, of course, digging around for some data specific to Tennessee. And at that time, I was just extremely alarmed, and so I started asking people, it's like, do you have any idea what's going on, other leaders in our community? And I described this particular problem as a tsunami because of the steep epidemiological curves that I was seeing, depending on which indicator I was looking at. And I thought, wow, if we don't get a handle on this, it's going to wipe us out as a country. And I don't think that was an exaggeration, and I think you'll see it as we go through the slides, that the epi curves, normal epi curves are very gradual, even if they are increasing. And this was a pretty steep upward trend in a lot of these indicators. So this is going to be, because this is part one, it's going to be more data heavy than what I'll cover next week. Next week's will be a little more action-oriented, what you can do with the data that you got and the information you received from this particular presentation. Next slide, please. So really what we want to accomplish today is just to understand the epidemiology of the prescription drug abuse problem, identify trends in Tennessee, and then understand how to interpret data to move upstream. Next slide, please. And so it begins. You can kind of trace this problem back to the 1980s and 1990s. There was a New York City pain specialist named Dr. Russell Portnoy, who is very prominent pain specialist, and did a lot of lecturing during that time, basically saying that less than 1% of people with chronic pain were actually being treated appropriately. So he touted that we had an epidemic of untreated pain in our country. As a result, in 1998, the American Pain Society pushed pain as the fifth vital sign, and Portnoy at that time was president of that society. And at the same time, around that same time, Joint Commission published a guide sponsored by Purdue Pharma along those same lines, that we were under-treating pain. And so Purdue Pharma is who is the maker of OxyContin. Next slide, please. So when you look at OxyContin and the promotion and marketing of OxyContin, it was really, from a business standpoint, a huge triumph, a huge win. But at the same time, it was creating a real public health tragedy. So in December 12th of 1995, the FDA approved extended-release OxyContin. And in 1996, so just a year later, they had $45 million in sales. By the year 2000, they had $1.1 billion. And then by 2010, they had $3.1 billion in sales and had a third of the opioid narcotic market. And then in 2007, they were actually charged with, had a felony charge for misbranding their product and were fined $600 million, which sounds like a lot of money to those of us here in prevention and work on shoestrings. But when you look at what they made, $600 million was a slap on the wrist compared to, what they had made over that time period. So what they did in their misbranding, when OxyContin first hit the market, of course it was extended release, so it lasted, for at least 12 hours, and they marketed the product as the first long-acting opioid narcotic that would not cause physical dependence and or addiction. So, which is why, you saw the product really skyrocket in sales, because doctors all thought, wow, this is the panacea of pain relievers. Finally, one that we can prescribe that's long-acting and that is non-addictive. But we found that not to be true. Next slide, please. Again, it was an epic error. In December of 2012, a Wall Street Journal article interviewed Dr. Portnoy. Dr. Portnoy and other pain doctors who promoted the drugs say they erred by overstating the drug's benefits and glossing over the risks. This is a quote from him. "Did I teach about pain management, specifically about opioid therapy, in a way that reflects misinformation? Well, against the standards of 2012, I guess I did. We didn't know then what we know now." Next slide, please. At the same time, there was also a real effort to make sure that patients were happy with the care that they were getting in healthcare systems, primarily hospitals throughout the country. So the pain satisfaction or patient satisfaction surveys really started hitting, and there was actually the Center for Medicare and Medicaid Services actually withheld a certain portion of the Medicare and Medicaid payment to hospitals based on their scores with their patient satisfaction surveys. It is a 26-question survey that patients are randomly selected to complete, and out of those 26 questions, there are 3 questions specifically related to whether or not that patient's pain was managed to their satisfaction. Many hospital administrators, because there was a financial incentive for keeping their scores up, put a lot of pressure on physicians to keep their scores high. And in fact, I actually visited an emergency department several years ago, and the physician there who ran that ED actually showed me on a bulletin board where, all the physicians and everybody working in the emergency department could see everybody's current patient satisfaction score. So I called it the wall of shame. So if your patient satisfaction survey scores were low, everybody knew it, and you were pressured by your colleagues as well as hospital administrators to get those back up. So we had all of these things, kind of converging at the same time. So medical providers felt a lot of pressure to prescribe when in some cases they may not have. So it created expectations among patients that they shouldn't feel any pain, and that if their pain wasn't adequately treated, they could ding the doctor. Next slide, please. So when you look at the epidemiology of prescription drug abuse in the U.S., you can see that this graphic says 52 million people in the U.S. over the age of 12 have used prescription drugs non-medically in their lifetime. So this is the kind of stat where you're asking, have you ever used a medication that wasn't meant for you or prescribed for you? So, that number is normally going to be higher than what if you ask somebody, in the last 30 days, have you used something non-medically? Next slide, please. So this is a little bit confusing here. So you've got 6.1 million people who have used them non-medically in the past month. So again, most epidemiology data and data that you see that have those two questions, you will see a lower number with the last month's use than you will see in lifetime use. So something's a little different here than what we're used to seeing. Another thing I wanted to point out on this particular slide is that the United States is 5% of the world's population, but yet we consume 75% of the world's prescription drugs. Now that's all prescription drugs. We actually consume 99% of the world's hydrocodone. So obviously the U.S., we really like our drugs and like our pills. Next slide, please. This graphic just really shows the parallels in opioid sales, opioid deaths, and opioid treatment admissions from 1999 to 2010. As you can see, this was published in 2015. That's what can be really frustrating about data and trying to track data over time is a lot of times there's such a lag in getting this data out there. And so we always feel as prevention folks, we feel a little behind the eight ball. So any ways that we can collect data locally that can give us, a more current picture, it's definitely to our advantage to try to develop those systems to get more real-time data. But the reason I'm showing you this is that you can just see the steep curve up, like I mentioned at the beginning, upward trend over a short period of time in all of these areas. Next slide, please. Overdose deaths, you can see hydrocodone and oxycodone are the two most prevalent drugs that we see in overdose deaths in the U.S. related to narcotics. And the blue bars, of course, are the total, and then hydro is red and the oxycodone is green. So hydrocodone is definitely the narcotic of choice in the U.S. Next slide. Is it a coincidence that all of this is happening and that there's parallels with all of this? Absolutely not. And anytime you've got increased prescribing and sales of something that's addictive and potentially deadly if misused, you're going to see all of that tie in together. Next slide, please. National overdose deaths. This one just basically shows you the differences, males and females. So again, we see that both genders, this is affecting both genders, males are a little higher, but you can see that the upward trend, is very similar, so there's not much difference in gender there. Next slide, please. Another thing that I'm extremely passionate about that unfortunately has been a negative outcome as a result of this too is neonatal abstinence syndrome, which is basically a conglomeration of symptoms a newborn can experience if they've been exposed to opioid narcotics or even heroin, the pure opiates, due to their mother taking it during pregnancy. And these are withdrawal symptoms, so we know how painful withdrawal is if we've, hopefully not many of us on here have had to experience withdrawal symptoms from opioids, but it's an extremely painful and uncomfortable process. And essentially newborns are going through that same pain and discomfort that an adult would go through. So 33% of childbearing women take prescription opioids, which is absolutely insane. Many of them are prescribed opioids during pregnancy for things such as, discomfort. Sometimes you'll have the baby pressing on a nerve, and so doctors, want to help women be more comfortable, but to be honest with you, being pregnant is not comfortable anyway. So, there's been some real prescribing habits that we've been working on trying to get doctors to all understand how prescribing to the mom, is being transferred to the fetus, and that they need to be thinking about that before they do it. From 2004 to 2013, the incidence quadrupled. The NICU stay increased from 13 to 19 days. Again, that's an average. We are seeing the NICU length of stay going down now, mainly because of medical management, and the more that they're learning about how to manage these babies, the better that they're able to manage the medications they use for weaning and take them, taper them down a little more quickly than they did initially. So chronic opioid use during pregnancy is a big deal, and it's very important to make sure people understand that. Next slide, please. This just shows you, this is another good piece of data. If you're tracking NAS, that is published on the Tennessee Department of Health's website. They began a NAS registry in 2013 and asked hospitals to report any cases of neonatal abstinence syndrome to the State Department of Health. So it became a reportable condition. So these charts, unfortunately, when you go to put them on a slide, they're a little fuzzy, so it's a little bit hard to see. But you can see at the end of 2016, we had 991 cases. We had 986 in 2015. So what that means is we're starting to see a leveling off of those numbers, where we were seeing a fairly steep increase annually prior to this. So that's good news on the prescription drug front is we're, again, once you see in an epi curve, once you start seeing numbers level off and get more stable, then you have an opportunity to see those actually decrease. So it's always hopeful when you don't see the increases anymore, and you know that something you're doing is having an impact there. But you can see on this slide, too, that if you look at where those cases are occurring, it's primarily East, Northeast, Sullivan County, Knox County have the highest prevalence. There's Upper Cumberland has had, quite a few cases of neonatal abstinence syndrome as well. But it's primarily more predominant, from on the east of Nashville and throughout the state, the Appalachian region of the state. Next slide, please. Some states have more painkiller prescriptions per person than others, and this graphic just really shows what I wanted you to see in this, is just that Tennessee, of course, is in the middle, literally, of a hotbed of prescription drug abuse. And so you can tie some of this into the Appalachian region, which has some of the highest rates. But it's just good to kind of know. It's been interesting to see that it's starting to move a little bit more west, too, in the western part of the U.S. Next slide, please. So, and I apologize, this is, a year old. We have 2015 overdose death data now, but which is 1,451. But the reason I show you this graph is it's really a good way of letting you know that the overdose death numbers that you see are really the tip of the iceberg of what's going on here in Tennessee. So for those who died in 2014, there were 12,630 treatment admissions for abuse, 32,838 emergency room visits for misuse or abuse, 136,404 people who abuse opioids or are dependent, and then almost 1 million non-medical users. So it's really astounding when you think about it in that context, that when you look at those overdose death numbers, that is just, again, a very, very small snapshot of what's truly going on here in Tennessee. Next slide, please. So three of the top 5 most prescribed medications from Tennessee's Controlled Substance Monitoring Database are opioids. So hydrocodone, I mentioned earlier, is the drug of choice here in Tennessee. Alprazolam, which is a benzodiazepine, most of you would know it as Xanax, is the brand name. And then the oxycodone products, which are also opioids. Then you've got a sleep medication, and then tramadol. So all of those are addictive drugs and can be potentially deadly if misused and abused or mixed with other medications. Next slide. How people in Tennessee died in 2014. Again, I think it's just good to kind of see how opioids are affecting Tennesseans and who's dying from what, especially when you're doing any kind of advocacy work. And you can see here, diabetes is killing more people annually, or it did in 2014, than opioids and pneumonia and flu. But drug overdoses are beating out, people getting getting shot, and then motor vehicle accidents. We all know it surpassed motor vehicle accidents several years ago. So again, it's important to know this. So as you're educating folks in your community, and they may say, well, hey, I hear that more people are dying from cancer than dying from drug overdoses, you can say, well, actually, it's the third leading cause of death, and it's behind these particular diseases. So this is good data to know when you're out doing advocacy work. Next slide, please. In Tennessee, we have our Controlled Substance Monitoring Database, and that database actually measures how much is being not necessarily prescribed, because information is not entered into the database until it's actually filled by a pharmacy. So a lot of people think this is all prescriptions written, and that's not the case, because my doctor may write me something just in case I need it for pain, and I decide I don't need it, and I never get it filled. So that is never counted in here. So what you're actually seeing here are medications that actually got filled at a pharmacy and were dispensed to a patient. So not all narcotics are created equal. So in order to be able to compare and really monitor what's going on, the state Department of Health breaks it down into milligram morphine equivalents, which are what MMEs mean. So for every drug, it's compared to a milligram of morphine. So if a certain narcotic is 10 times more powerful, the morphine equivalent is 10 to 1. So I just kind of wanted to explain that because there is variation in the milligram equivalents for each drug that's dispensed. So this kind of levels the playing field so that we really understand what's going on here in Tennessee. But you can look at from 2010 to 2015 the total MMEs that have been per capita that have been dispensed here in Tennessee. So you can see that we're seeing a downward trend. In 2012, the Prescription Safety Act was put into place, which required all licensed DEA holders in Tennessee so they're able to prescribe narcotics. So that would be nurse practitioners, PAs, and MDs to register with a database. And it also required that they do a lookup on a patient before they prescribe a new narcotic. And if someone is on a long-term opioid or benzodiazepine, they're required to check again every 6 months. So we really have seen some behavior change among providers and prescribers since that act went into place. Next slide, please. So Tennessee opioid prescribing volume by specialty. Most of us would think, you know, it would be oncologists, hematologists, even surgeons that would be very high up in the prescribing of these narcotics. But you can see here this graph really shows you, this data shows you that the problem was not where you would think. The high prescribers were not the specialty areas of medicine that you would expect to see here. So family practice and nurse practitioners were very high, and internal medicine. So, you know, you've got surgery, you know, coming in there at fifth. And again, you would expect surgeons to be prescribing for post-op pain narcotics a little more frequently than a family practice physician. So there were some trends there that we, the state really looked at and said, you know, we've got a problem with our highest prescribers, and so they started sending letters out to the top 50 prescribers on an annual basis, asking them to respond back by letter why they were in the top 50. You know, what are you doing? And just as a result of sending that letter and causing response, they usually have some drop off the top 50 and change their prescribing patterns. But there's still quite a bit of work to do there. And you can see in there too, dentistry. I think that's one thing we don't think a lot about. But dentists also prescribe a lot of narcotics. So that's another area of medicine that sometimes I think gets overlooked. Next slide, please. Controlled substances, this is Schedule 2, so these are your most powerful narcotics. And you can see Tennessee ranks second in per capita in Controlled 2 substance utilization. Next slide. This one got a little out of whack here. I apologize. This is just showing the difference in substance growth by state of that same classification, the Controlled 2 substances, from 23 versus 2012. So you can see we rank 31st in changes in growth. So we slowed our growth down quite significantly, which is a positive indicator. Next slide, please. Problem in Tennessee, this is just another thing to kind of monitor a good piece of data. And this data is available online that you can get to track treatment admissions for at least facilities that have state beds. So this isn't capturing private treatment admissions, but this at least, again, is another indicator that we can track over time. And I really like this now because we're really talking a lot about medical marijuana and legalization of marijuana for recreational purposes, and I think this is a compelling slide to really demonstrate that people can get addicted to marijuana and go to treatment as marijuana, listing marijuana as their primary substance of abuse. But let me draw your attention back to the red line. That is our opiate treatment admissions, and you can see that in really in 2007 it was equal to cocaine and then surpassed cocaine in 2008. Next slide, please. And I always like seeing these maps. They're another good data indicator to kind of watch your state and how your state compares with others. I call this the darkest before the dawn slide because you can see Tennessee has one of the highest prescribing rates per 100 people in the nation. So we have a lot of work to do. But this is 2012, so you saw the MME slide earlier. If we saw a map today, hopefully our color wouldn't be quite so dark as it is in this slide. Next slide, please. We talked about MMEs per capita. I just wanted you to see this is 2014 data, county level data. So you can kind of see based on where you're located in the state, where you fall in there. Are you in a area that's darker, which has a higher average of MMEs prescribed or filled per capita, or whether you're in one of the lighter areas. Next slide, please. And then this shows kind of at the regional level. Again, it's good to look at it from a county and a regional standpoint. We all know when we're doing this work, the problems don't stop at the county lines, nor do they at the state lines. So it's always good to know what's going on around in our neighboring communities as well. Next slide, please. This is changes in MMEs from 2013 to 14. So you can see like the East region looked really, really bad on the previous slides, and you can see this is the fastest growing region for improvement. So again, it's good to have this information and this data so that you can track and trend things and know what you need to continue to focus on in your community. Next slide, please. I realize some of you aren't from East Tennessee, but I really wanted you to see these particular slides because, again, East has had some of the most dramatic changes in their prescribing. So I think these next few slides showing the East decrease shows that we can have impact in this problem if we all work together and develop some very sound strategies in doing so. Next slide. Of course, I had to have Knox in red. Next slide. So you can see, over that time period, the difference in the changes in the regional map for East, and we're very happy to see that. Unfortunately, in Knox County, we have not seen that same trend in overdose deaths, and in fact, they're continuing to climb. Next slide, please. Again, this is just another piece of information that shows our overdose death rate. Next slide. Our medical examiner's office has been great about going back and really putting together some data for Knox and Anderson counties. This is Knox County's data in particular. And what I really wanted to show you here is if you can get this county level death data, our perception was mainly because the ones that we were hearing about in terms of losing, we were hearing about the 20-year-olds. And so our perception in our community before the ME's office put this data together was that it was young people dying from drug overdoses. And this was probably the most compelling piece of data we got out of their study, was the fact that it's middle-aged folks, it's mothers, it's grandparents. It's not necessarily 20-year-olds. So again, you know, this piece of data can really help you target in your communities, if you can get it at this level, targeting the right populations and being able to use your resources more wisely. Next slide, please. Again, just to kind of wrap up the adverse outcomes in Tennessee, again, we had in 2015, we had 1,451 overdose deaths. In 2016, we had almost 1,000 babies born with neonatal abstinence syndrome, but that number seems to be stabilizing. And then we have more treatment admissions for our state treatment beds than we have for addiction, treatment admissions for addiction for this problem than alcohol. And I don't think any of us ever thought there would be a drug that would surpass alcohol. Next slide. Now we will open it up for questions. So if anybody has a question, you can either use the chat box or you can unmute your phone, I'm assuming, Leah, and they could ask it verbally.
Yes, I muted a couple people who had background noise.
Okay.
But everybody else should be able to unmute or type in the chat box.
I know that was a lot of data, everyone, but
no questions? I'm not seeing anything in the chat box.
Nothing in the chat box.
You were just so thorough.
Gosh, I must have really done a good job, or else everybody went to sleep and are bored with all the data.
Well, they want to know if they can get slides, but I do have those. I can send those out.
Yeah, Leah can send those out to you.
I'll send a follow-up email that will include those, as well as the link to rewatch this since we're recording. Timothy says, very nice job. Thank you, Karen.
Well, thank you. And next week's, for those of you, next week's will be a little more, you know, how to apply this information to do work in your local community. So it'll kind of get where the rubber meets the road.
Great. Okay, well, I put the contact information up for Karen, and also you should see my email address in the chat box. If you need a certificate or if you have any questions, please feel free to email me anytime. It doesn't even have to be related to this, anything prevention related, I'm here. And thank you all so much. I hope you're able to make it on the call next week.
Thank you all, and have a great weekend.